All right, let's get right into it. Today, we're going to break down a really important article from the European Journal of Radiology. It gets to the heart of a tough question. Why are some breast cancers still so deadly? We're going to look at the specific subgroups that, even with all our modern tools, are proving to be disproportionately fatal. You know, it's a question that I think everyone in this field asks themselves. We've got incredible screening tech, we've got modern therapies, mortality rates have definitely dropped, but still, for some women, this disease is fatal. So why? What are we missing? And that's exactly the challenge this research takes on. Well, the answer, or at least a big part of it, might just come from the pioneering work of Professor Laszlo Tabar. His group has literally spent decades on this, and they've developed a whole new framework for how we should think about breast cancer. The key takeaway? It's not just one disease. It's a collection of distinct subtypes, each with its own origin, its own way of growing, and, this is the critical part, its own outcome. So here's what we've got on tap. We'll touch on that big question again, then we'll dive into Tabar's patterns of origin, we'll look at the fatal subgroups, walk through some really insightful case studies for both multifocal and diffuse cancers, and wrap up with how we can actually improve patient outcomes. Let's get started. Okay, section 1, the lingering question. You know, for a long time, we've kind of thought about breast cancer as a single tumor mass, but the article makes a powerful point. That's just not enough. It misses the most important question. How is this cancer actually growing? Is it one neat little lump? Is it a bunch of them? Or is it something else entirely, just spreading through the tissue? And that right there brings us to section 2, Tabar's patterns of origin. This is the heart of his work. It's a whole new classification system. Instead of just looking at the pathology after the fact, his team uses what they call imaging biomarkers. Think of them as visual clues, specific patterns you can see on a mammogram that tell you where the cancer started and, more importantly, how it's going to behave. Okay, this slide is like a Rosetta Stone for these biomarkers. Let's break it down. On the left, you've got the signs for what's called acinar adenocarcinoma of the breast, or AAB. See those star-shaped or stellate and circular masses? And look how perfectly the mammogram pattern matches the pathology right below it. It's incredible. Now, in the middle, those are casting-type calcifications. They look like little broken lines, and they're the calling card for ductal adenocarcinoma, or DAB. And finally, on the right, that's architectural distortion. It's the biomarker for breast cancer of mesenchymal origin, BCMO. There's no real mass, just this pulling in of the tissue. It's a subtle but crucial sign. In this image just drives that point home. It shows you the growth patterns that those biomarkers predict. So, on the far left, that's your classic unifocal AEB, one single tumor. Simple enough. But right next to it, that's multifocal AEB, not one, but many different tumor sites. Then you get to the diffuse cancers. You've got DAB spreading all through the ducts and BCMO just infiltrating everything, often without a real mass you can point to. The difference between that one little dot on the left and the widespread disease on the right is, honestly, it's profound. And it's everything when it comes to patient survival. So that's the theory. But does it actually hold up in the real world? Let's get into section 3, the fatal subgroups. The researchers looked at over 2,400 cases of invasive breast cancer and classified them using these patterns. And what they found, well, it's a pretty stark and sobering look at which of these cancers are the real killers. 71%. Just let that number sink in for a second. It's a huge number, and it represents a massive, massive disparity in who survives breast cancer. The next slide will show you exactly what I mean. Okay, this is the whole story right here in 2 charts. Look at chart A on the left. All those multifocal and diffuse cancers we just talked about, the multifocal AAB, DAB, and BCMO, they make up about 45% of all cases. So less than half. Now look at chart B. That same group, that same 45% of cases, is responsible for a whopping 71% of all deaths. It's just staggering. A minority of the cancer types are causing the vast majority of the mortality. And if you want to see that play out over time, look at this survival curve. It's incredibly powerful. That blue line way up top, that's your unifocal AAB. Pretty good long-term survival. But then look what happens. The green line for multifocal AAB takes a significant dip. The black line for DB drops even further. And then the red line at the bottom, that's BCMO. Survival just plummets. You can't argue with that visual separation. It shows you clear as day how powerful this classification system is for predicting a patient's future. All right, so let's move from the data to a real-world case. Section 4 is a case study on multifocal disease. And this is so important because the article makes it crystal clear that having multiple tumor sites is a bad sign all on its own, mainly because it's so easy to underestimate just how much cancer is actually there. So here we have a 35-year-old woman. She has dense breasts. And take a look at her mammograms, images A through D. She actually felt a skin retraction, but the mammogram, it's basically negative. No mass, no calcs, no distortion. It's what we call mammographically occult. But then, you do an MRI, and look at image E. It just lights up with extensive non-mass enhancement. So you follow that up with an ultrasound, images F through J, and suddenly you start finding one little tumor focus after another. And this right here is the moment of truth. This is classic Professor Tabar, demanding that we correlate our imaging with the actual pathology. So image K is a radiograph of the specimen after surgery. And image L, that's the large format histoslide. And you can see where the pathologists have circled the cancer. Count them up. There are at least 7 distinct tumors there. It absolutely confirms this was a multifocal cancer and it was completely invisible on that initial mammogram. And it just keeps going. Look at these other slices in M and N. The total area of disease is a massive 75 by 38 millimeters. But get this, the biggest single tumor they found was only 11 millimeters. So the total tumor burden was huge. And that is exactly why multifocal disease is so dangerous. If you just plan your treatment around that 11 millimeter spot, you're leaving a huge amount of cancer behind. Okay, now for Section 5, let's look at the diffuse cancers, the DAB and BCMO subtypes. If you thought multifocal was tricky, these are a whole other level. They're even more aggressive, and their signs on imaging can be incredibly subtle or even just plain misleading. Okay, case 2. This is a 51-year-old woman, extremely dense breasts. Check out her mammograms in A and B. All you can really see are these faint, kind of skipping stone-like calcifications. It is super subtle. But then you put her in the MRI scanner, and bam, image C tells the real story. You see this extensive non-mass enhancement just lighting up an entire lobe. That's the true extent of her ductal adenocarcinoma, the DAB. And here's what's happening at the cellular level. In images F and G, you can see the cancer cells literally invading the Cooper's ligaments. This is a key feature of DAB, and Professor Tabar has a name for it: neoductogenesis. It's like the cancer is building its own highway system, creating new malignant ducts that let it spread far and wide through all the connective tissue in the breast. And this slide just shows you how invasive this process is. Image K is a low-power view of the tissue right under the skin, and look at that, a huge cluster of those malignant neoducts. This is proof that the cancer has spread all the way to the skin and the nipple. It really drives home just how aggressive this type of cancer is, and why it's so easy to undertreat it if you don't know what you're looking for from the start. And now for our last case, and it's the most fatal of them all, BCMO, which you might know as invasive lobular carcinoma. We have a 53-year-old woman who felt a thickening. Look at her mammograms, A through D. They're completely 100% negative, nothing, mammographically occult. And that is terrifyingly common with this subtype. The only way they found it was by throwing everything at it: AI, ultrasound, and MRI. And only then did the true extensive nature of this cancer become clear. Okay, so this patient got chemo before her surgery. And this slide, this is the pathology after all that treatment. And look, even after chemo, you can see in image K, there are multiple, viable, active cancer spots still there, just spread all over the place. It just goes to show you not only how widespread BCMO is, but how incredibly resistant it can be to our therapies. And finally, let's zoom all the way in. Images L and M are high-power views, and you can see the cancer cells infiltrating in those classic single-file lines. This is the why. This is the pathology that explains why BCMO is a ghost on mammograms. It doesn't clump together to form a mass. It just silently weaves its way through the normal tissue, and that's what makes it so incredibly dangerous. So, wow, after seeing all those challenges, the big question is, what do we do about it? How can we actually improve outcomes? Well, that brings us to our last section, which is all about shifting from diagnosis to action with real, practical steps for the entire team. The paper lays out a really clear roadmap. First, use these imaging biomarkers from the get-go to predict how a tumor is going to act. Second, use breast MRI before surgery to map out the entire tumor, not just the tip of the iceberg. Third, we have to talk to each other more. Better communication between the surgeon and radiologist during the operation and between the radiologist and pathologist after. Then, do that deep dive imaging pathology correlation on every single case. And finally, make sure the final report actually includes his crucial information about biomarkers and growth patterns. It all has to be in there. And we're going to leave you with this fantastic quote from the article because it just sums it all up perfectly. It says that consensus decisions at pre-treatment planning conferences are a golden opportunity to maximize benefits and minimize risks. It's not about one person being the hero. It's about the whole team. Radiologists, surgeons, pathologists, oncologists, all working together. And as Professor Tabar's entire career has shown us, that collaborative spirit, that dedication to correlating what we see on the screen with what's actually happening in the tissue, that is the absolute key to beating these cancers and saving more lives.